Good afternoon, everyone, and welcome to the Lynn Cancer Institute updates. We're keeping you in the know in 2023. We're very grateful to have you all with us today and to learn from our very own physicians who will be educating us on the newest information on prostate cancer. At the Lynn Cancer Institute, we believe that education, prevention, screening, and early detection, a variety of our treatment options, the expertise of our staff, and our latest technology will truly save lives. In the interest of time, our physician speaker bios were sent to you by email, and they will be resent with the evaluation. Your Zoom will be muted during this presentation, so we invite you to take notes. And if you have any questions or comments, please put them in the chat box or the Q&A box, because the speakers will not be able to see you or hear you during the presentation. There will be time at the end of the presentation for questions. So now we're very proud to welcome you to the Lynn Cancer Institute. And our speakers today will be Dr. David Taub, urologic oncology and urologic surgery, Dr. Michael Casper, radiation oncology, and Dr. Edgar Castillo, medical oncology. And we're going to begin our presentation with Dr. Taub. Thank you, Dr. Taub.
Thank you, Jan, and thank you all for taking the time to join us. Good afternoon. We're so excited that you're here. We wish and can't wait to be back in person at some point in the future, but this is a great way of reaching people and still everyone continuing their days. So we're going to talk to you a little bit about prostate cancer. There we go. There we go. So here's what I'm going to talk to you about an overview about prostate cancer, how we screen or diagnose prostate cancer, and then some surgical treatments. And then I'll turn it over to my esteemed colleagues for more radiation and medical oncology information. So I'm a urologic oncologist. I treat cancers of the prostate, male reproductive system, and urinary system in men and women. So the adrenal glands, the kidneys, bladder, prostate, testicles. Prostate cancer is the most common cancer in American men. Over 288,000 new cases are estimated for this year, and over 34,000 men are presumed to die of this disease of prostate cancer this year. So this is a quick diagram of the prostate. The prostate gland is in red in the middle of your screen. It is a male reproductive gland. It produces nutrients and fluids to help sperm impregnate a woman's egg, and it surrounds the urethra channel. So as men get older, the prostate grows and it pinches off that urethra channel a little bit, making it more difficult to urinate. The average age at diagnosis is about 66 years of age. 1 in 8 American men will be diagnosed in their lifetime. Risk factors are genetic mutations, in particular the BRCA gene. A strong family history is a risk factor for prostate cancer, especially first-degree relatives, a father or brother, grandfather. African American men are more likely to have more aggressive disease. The mortality has decreased from a peak of 40,000 in the mid-1990s, but increased a little bit over the past several years as the U.S. Preventative Task Force recommended against prostate cancer screening temporarily, and then we've seen the ramifications, and now we're back to doing it on a yearly basis. So how do we screen for prostate cancer? Generally, it's men ages 45 to 75. They should have a life expectancy of over 10 years because prostate cancer, even aggressive prostate cancer, tends to grow a little bit on the slower side, and so it shouldn't cause harm right away. For higher risk men, we start earlier, but never really before age 40. How we screen is we take a medical history. We ask about urinary function, family history of different types of cancers, sexual function. We do a prostate exam, also known as a digital rectal examination, or DRE. We check a blood test called a PSA. Often that's done with your routine yearly laboratory work for prostate specific antigen. It's higher in men who are at higher risk for prostate cancer. And then if there's an abnormal prostate exam or an abnormal PSA test, patients are referred to a urologist, and we complete the workup with an MRI, an ultrasound of the prostate gland, and sometimes a biopsy if it's necessary. So MRI is a nice step. We used to just go from an elevated PSA to a prostate biopsy. The MRI hardware and software have improved, just like our cell phones over the years. And in 2013, 2014, we started getting a better picture of the prostate gland and grading different lesions or areas in the prostate, and higher numbers are concerning for a higher risk of cancer. And so those men might need a biopsy. So we fuse our transrectal ultrasound probe, which can in real time visualize the prostate, with the stored MRI images and target specific areas of the prostate to get a much better, more precise diagnosis. So higher chance of detecting higher risk disease, and quite frankly, we diagnose less clinically insignificant cancers that aren't likely to harm the patient. So once we have a prostate cancer diagnosis, we move on to treatment, and that depends upon the grade or the degree of aggressiveness, the stage, how advanced is it, has it spread or whatnot, the patient's age and overall health, patients' personal preferences about their cancer care, and genomic testing. And that last one is something that we've been doing for the past several years, and it's a bit of more personalized medicine. So we send the biopsy material to be analyzed for underlying genetic activity that can predict disease aggressiveness and provide more personalized information. This is an example of a report that we might get. Basically, by measuring the tumor biology through expression of 17 genes, we are more able to predict the likelihood of adverse pathology, which is defined as more high-grade disease and disease that is not any more confined to the prostate. Has it gotten outside the capsule of the prostate or into the seminal vesicles or local lymph channels? So this is a picture at night of our building, the Lynn Cancer Institute. My colleagues and I are fortunate to work in this beautiful building and be able to care for our patients with the latest technology. Here's a overall listing of what we have to offer, but we have fellowship trained specialists in medical oncology, radiation oncology, surgical oncology, genetic counseling, and we have even a special pathologist who's done extra work in urologic oncology, as well as ancillary services such as nutritional support, social work support, and clinical trials for more advanced or aggressive diseases. So now we're going to talk a little bit about surgery. One thing that urologists manage is actually active surveillance. So some of our patients with particularly low volume, low risk, non-aggressive disease that are not going to be harmed by their cancer, the right thing to do is to watch them closely rather than do a more radical treatment such as surgery or radiation. And then we're going to talk about surgery and new techniques, which is focal ablation of the prostate. So robotic prostatectomy, the goal is to remove the prostate cancer entirely. It's got very high cure rates for localized disease. And with the robotic technique, we're able to preserve urinary function and sexual function, Second benefit is that we're able to analyze the entire prostate and see which of our patients are at higher risk for recurrence or relapse and may benefit from additional treatments such as radiation. So it gives us a second treatment, a second kind of bite at the apple to get rid of the cancer if it is particularly aggressive or um, large. So a quick overview of the surgical system we use. We use the latest Da Vinci Xi surgical system. We've done over 1,000 of these procedures. It's a computer enhanced device, not truly a robot. The surgeon operates at a console immersed in the 3D and magnified image of the surgical field. And there's an assistant surgeon at the bedside to pass instruments or needles and suction and things like that. The instruments are quite small. They're wristed, which mimics a human wrist, unlike our older laparoscopic equipment. And this allows for increased dexterity, precision, maneuverability in a tight area, which ultimately is going to lead to less blood loss, less trauma, less pain, and just quicker getting back to your normal life. So we talked about surgery. So focal therapy is relatively new, and it fills an important treatment gap in prostate cancer care. So with advanced imaging, we talked about MRI fusion targeted biopsies with genomic testing. We're now able to localize the disease and really risk stratify patients' prostate cancer. And so for patients who, some patients want some option between just keeping an eye on it and more radical treatments like surgery or radiation. And focal therapy, HIFU is mentioned in this particular slide, which stands for high intensity focused ultrasound, but there's a number of energy modalities, is able to provide a safe, effective, and less invasive option for patients with low and intermediate risk disease and as well as salvage therapy or relapse after radiation or surgery. So this kind of picture on the right shows what we're seeing more and more commonly, where there's an MRI lesion and the biopsy is positive only in that area, and we can target that specific area of the prostate with a margin around it rather than the whole prostate, which can lead to less toxicity in terms of urinary function and sexual function. HIFU is high intensity focused ultrasound. Cryotherapy is freezing the prostate gland. There's a potential to do that with radiation seeds or radiation. Also with something called irreversible electroporation, also known as nanoknife. And the key here is really only select cases are eligible. It has to be not very aggressive disease. It has to be localized to one area. So not everyone is a candidate for this option, but if patients are, it is a good option for them. There's an abundance of clinical evidence on focal therapy. There's over 1,000 peer-reviewed publications. There's reproducible results, including a systematic review of over 4,000 patients, showing cure rates from 78 to 95%, urinary control of over 98%, and sexual function preservation of over 80%. So this is a picture of the new Focal One HIFU machine. We're fortunate to be adding this to our comprehensive armamentarium of prostate cancer care at Lynn Cancer Institute. It's got also a kind of robotic arm where once you fuse the MRI and biopsy lesion with the live ultrasound and set the parameters for treatment, the machine will particularly avoid the rectum and do different things to make sure it stays within that little area. So we're very excited. We will be adding that to our prostate cancer bag of tricks in November or December of this year. And that's all I have on the surgical management. I'm going to turn it over now to my colleague, Dr. Casper, who's the head of radiation oncology here, and just fortunate to have worked with him for the last 7 years, and look forward to many more. And we'll be happy to answer your questions afterward.
Okay, well, thank you, Dr. Taub. That was excellent. I always learn a lot when I hear Dr. Taub speak, and I've learned so much from him over the years. Early on, he taught me how to pick the best urologist. And I said, you know, how do you pick the best urologist? He said, look for the one with the smallest fingers. So I've used that advice. But excellent, actually, excellent talk. And my talk is going to be a little bit shorter, a little bit more direct about radiation oncology. I'm going to update us on some new technology that we have at the Lynn Cancer Institute. But I'm going to start by talking about our multimodality clinics. And Dr. Taub mentioned this and alluded to this, but you know, it's true, and you can see here that good medicine and top-notch cancer care requires not only the best technology, which we're very fortunate to have here at the Lynn Cancer Institute, but also on hiring the best people and then providing them with the opportunity to work with other top individuals from other medical disciplines. And we're fortunate to be able to have people who are really focused on their disease site. And we are able to do that in radiation oncology here, where in many other areas, people will treat all different sites. And it's hard to be an absolute master of all disease sites. But when you can focus on 1, 2, or 3 different sites, you can go to the national meetings, you can participate in their clinical trials, you can really comprehensively scour the literature and become an expert in that area. And it's very fortunate that we're able to do that here at the Lynn Cancer Institute. One of the features that really sets Lynn Cancer Institute apart is the multimodality clinics, where we have our site-specific cancer surgeons, medical oncologists, radiation oncologists, as well as the radiologists, pathologists, psychosocial experts, dietitians, who all meet with the patient at the same time. It's not just a conference, but it's an actual clinic where we're meeting with the patients, and then we get together and discuss the patient's individual case and come up with the best disposition. We have time set aside to try to expedite imaging studies like PET scans, and it's really the best patient care. Patients love it. It saves time, 6 to 8 weeks in many instances. But even more importantly, the physicians are all directly discussing the case, looking at the same images, looking at the pathology at the same time. So everyone has all of the information and it's up to date, and we can do the best for the patient. So that really sets us apart. And we do this every Thursday, looking at prostate cancer patients, Dr. Taub, Dr. Castillo, who you'll hear from shortly, and all of the other team that Dr. Taub mentioned. Let me talk about radiation now. And I'm going to go back a little bit and talk about a little bit of history. We're very dependent on technology in radiation, as you might imagine, but there have been incredible improvements over the years, and we've seen great improvements in delivery of radiation therapy. Early on, we were limited to just 2-dimensional imaging, and you're going to see a slide in a minute demonstrating that. But we can only use X-rays and try to point and shoot as to where we saw the bony anatomy, and we knew where the soft tissue anatomy, or where the cancer most likely was located. And you know, we were fairly effective in targeting these cancers, but we were limited in the doses we could give because the fields were generally much, much larger. They included a lot of extra tissue, and we would cause side effects which limited our doses, and that really limited our ability to cure many of these cancers. Well, as time went on, computing improved. We had 3-dimensional imaging and planning, and we could actually see the tumors much better. That improved again with stronger computers, and we were able to do intensity modulated radiation, which was not only 3D imaging, but we could modulate the dose and really localize and avoid some of the soft tissues. But it wasn't until over the past 8 to 10 years that we started taking into account movement. Everything inside the body is not static. You know, everything moves with respiration, with peristalsis through the bowels. When we urinate, the bladder changes. So for the prostate, it's actually moves more than we ever appreciated before. And in the past, we accommodated for this by enlarging the fields again. We did 4-dimensional imaging, and that allowed us to see the extent of the movement, or the anticipated extent of the movement. And we just increased our fields by that amount. But again, that still increased our target volume and gave a higher dose to tissues that didn't need to be treated. More recently, we've added some technology that I'm going to show you that allows us to give the tightest possible margins. And that's stereotactic body radiotherapy, that's SBRT, with real-time MR guided image. So this is an MR machine married with a linear accelerator, which will manage any motion, shutting on and off the machine while completely visualizing the radiation, the prostate during the entire treatment. So this is what I was talking about. On the left side here, you see a 2-dimensional X-ray, and we could see the bones. You know, here's the sacrum. We know that the bladder is here and the prostate's sitting in here, but we couldn't really visualize it very well, although we treated and cured many cancers with this technology. And then as we developed CT scans and had better imaging, you can really see the bones pop out. We can see the bladder very nicely. We know that this is bowel, and still we don't have a great view of the prostate, but we know it's in here, and we could really do a better job with this, but not as good as we can do today. And now on the right, you see the images that we're getting on our MR Linac. This is the Meridian MRI, name of the MRI machine, the MR Linac that we have. And you see a very crisp bladder here. You can see the urethra actually extending into the prostate. Here's the prostate, and here's the bowel that we want to avoid. We put a 2 to 3 millimeter margin around the prostate, and we're able to visualize this during the treatment. And if at any time the prostate migrates or moves out of that 3 millimeter margin, the machine will shut off. If you're getting a gas bubble that comes down the rectum here, it can bump the prostate and move. The machine will shut off if the bowel goes into the treatment field. We don't want to treat the bowel, so it stops the treatment. In the past, you know, we didn't realize this was happening, and we still did very, very well. But now we're doing even better because we know that we can avoid a lot of the side effects that we were causing. We're also able to now place something between the rectum and the prostate right here. There's a gel spacer. There are a couple of products out on the market, Spacer and Barrigel, and with a needle, we can place this gel very precisely under ultrasound guidance, and it has dramatically eased our treatment planning and ensured that we're able to avoid treatment to the rectum. Not only does it avoid any radiation to the rectum, it also makes it easier for us to plan for the bladder and other structures like the other surrounding structures that we want to avoid with radiation. So it really makes a big difference in our treatment planning. So this is the machine. This is the MR Linac that we have here in our office in Delray. And you can see it's a combination of a radiation linear accelerator and an MRI machine. And here are the guts of the machine. And you can see this is the radiation device here. And finally, the linear accelerator. And then I'm going to show you another little slideshow. This is what we see at the treatment console, this black area in the middle. This is going to zoom in here in a second, and you're going to see the prostate actually moving in and out of that red margin that we have set up here, the red target zone. And you'll see that the machine is shutting on and off based on the location of the prostate. You see if the patient breathes or coughs, or more frequently, we may get a gas bubble. We don't want the rectum or the bladder to be treated. So if the bladder comes into the field, the machine will automatically shut off. So essentially, we're getting a streaming movie of the live video feed, really, of the treatment. I mean, it looks simple, but there's an awful lot of upfront planning that goes into this, and contouring and design. But this is essentially what we're doing. So this complements all of the other equipment that we have. This isn't for everyone. Some people are claustrophobic and can't go into the MRI machine. We tend to use this for shorter treatments, and some people need longer treatments because of lower urinary tract symptoms like very large prostates and very narrow urethras. We usually have to avoid that. But many of our patients are candidates, and we've been very pleased with the early results over the first 4 or 5 months that we've been using this. Okay, and I think that's all I'm going to talk about today. This is an old traditional slide here. But I want to thank you very much. We'll be open for questions shortly, but I'd like to turn it over to Dr. Castillo.
Good afternoon. I want to thank Dr. Casper and Dr. Taub for all the information they provided. I'm going to talk about systemic therapies for prostate cancer, usually for patients with more advanced disease. So let me open my slides. So I'm going to talk about treatments for more advanced prostate cancers. It's usually patients that have more advanced disease. Usually they're not candidates to get surgery or radiation therapy. We can see patients that have metastatic disease at presentation, meaning that the cancer has already gone outside the prostate, or patients that have developed metastatic disease, a spread of the cancer after definitive treatment like surgery or radiotherapy. We can usually find that on scans, or we can just see an elevation in the PSA without seeing anything on the scans. So the backbone of therapy, the cornerstone of therapy for treatments for patients with advanced prostate cancer is what we call androgen deprivation therapy. And these are medications that we give to suppress the testosterone levels because usually prostate cancer kind of grows when the testosterone is high. So to lower the testosterone, we can do it in either 2 ways. One way is surgically, basically by removing the testicles. That's rarely done. I haven't seen that done in a long time. Or medically, with medications that suppress the testosterone levels. And there are different medications, and they act in different ways. We have the GnRH agonist. Those medications stimulate one of the hormones that stimulates the production of testosterone by the testicles and the adrenal glands. And by doing that, this is a system that that uses negative feedback to regulate itself. So there is an initial increase in testosterone, and the testosterone goes down. And those are the medications that we use the most. They're called, one of them is called Lupron, the other one is called Eligard. Those are injections that we give. We can give them every month, every 3 months, or every 6 months. Then there is Soladex, which we use sometimes too. There is an oral medication called Orgovyx that we use sometimes. The androgen deprivation therapy or the suppression of testosterone can be done continuously. Most times we do that. We keep patients on these medications indefinitely, the ones that have advanced prostate cancer. But sometimes when they have side effects, we do this intermittently. So we give the medications, we wait for the testosterone to go low, and then we stop the medications and we monitor the testosterone levels. These medications are generally well tolerated, but they do have side effects. The things that we see more commonly are increased body fat. People can gain weight. They can have sexual dysfunction, like erectile dysfunction, loss of libido. They can have secondary osteoporosis. They can have what we call vasomotor symptoms, which is essentially hot flashes and sweating. They can have gynecomastia, which is increasing size of the breast tissue. They can feel fatigued or weak. They can have lack of energy. They can have some neurological side effects like depression. And then we see the metabolic side effects like high cholesterol, high sugars, and even increasing the risk of cardiovascular events like heart attacks. That's rare, but it happens, and it's important that patients know that before they start these treatments. In the past, we used to do androgen deprivation alone. So we used to treat patients with these medications just to lower the testosterone levels. And then when they would progress and they would become what we call castration resistant, meaning that the testosterone was down, but the cancer would continue to progress, we would add a second medication. Now, we usually do two medications in the front line. So we do the androgen deprivation therapy and we add a second medication. And we have different medications that we can use. We can add chemotherapy. There are two FDA-approved chemotherapeutic agents for advanced prostate cancer. One of them is called docetaxel. The other one is called cabazitaxel. And there are other medications that interact with the testosterone. One of them is called Zytiga. The other one is called Xtandi. The other one is called Erleada. They're all approved to use in combination with the androgen deprivation therapy. I'm going to talk a little bit about chemotherapy. We only use chemotherapy in the initial phase of the treatment for advanced prostate cancer for patients that have high volume disease, meaning that they have a lot of cancer, a lot of lesions in different parts of the body, or the patients that have what we call visceral disease, patients that have cancer that has gone to visceral organs like the liver or the lungs. So in that case, we use chemotherapy in combination with the androgen deprivation therapy. As we all know, chemotherapy has side effects, and the things that we see more commonly are low blood counts. We can see nausea, we can see vomiting, we can see allergic reactions, we can see infections, and chemotherapy can also affect other organs like the kidneys and the liver. So these are patients that need to be monitored closely, that need blood work before each dose of chemotherapy. We need to really see them frequently to make sure we are able to treat and monitor their side effects. One of the other drugs that we use very commonly is a drug called abiraterone. The commercial name is Zytiga. And this is a medication that inhibits an enzyme that is required for the production of testosterone. So it decreases the testosterone production in the testes, in the adrenal glands, and in the prostatic tissue as well. It has to be taken with prednisone, which is a steroid, to prevent some of the side effects that we can see, which are liver dysfunction, hypertension. We can see fluid retention. We can see electrolyte abnormalities like hypokalemia, meaning low potassium, and abnormal heart rhythms like QT prolongations and so on. The medication is generally well tolerated. Most people do fine with it, and it's usually very effective to control the prostate cancer initially. It's important to know that all these medications work well. It's important to know that when we talk about prostate cancer, even in patients with advanced disease, and we talk about prognosis and survival, most times we're talking about years, not months, like we see in other types of cancers. The other medications that we use commonly are a medication called enzalutamide, commercial name is Xtandi, or apalutamide, the commercial name is Erlida. These medications interact with the testosterone receptors in the tissues. And by doing that, they induce death of the prostate cancer cells. They're well tolerated. The most common side effects that we see are fatigue. People, they feel like they have no energy. We can see a slight increase in cardiovascular events like heart attacks. And it's rare, but seizures have been reported. So this is a medication we don't use in patients with history of seizures. Kind of the newer medication that we're using is a medication called Nubeqa. It's usually used in the initial phase of treatments with patients with advanced prostate cancers, the ones that are still responding to the testosterone suppression. This medication, it interacts with the testosterone receptors in the tissues, and by doing that, it induces the death of prostate cancer cells. It's well tolerated. It can cause increasing cardiac events like the other ones. Seizures are very rare, but the main side effect that we see is fatigue or lack of energy. For some patients, we use what we call triple therapy. This is usually for patients with high risk, high volume disease. And in those cases, we use a combination of the androgen deprivation therapy, meaning these hormonal medications that we use to decrease the testosterone levels. We use chemotherapy with docetaxel, and then we add a third medication. The two that we can use are the Nubeqa and the Zytiga. And then again, this is for patients with high risk, high volume disease, meaning patients that have a lot of disease, a lot of bulky disease, or patients that have visceral mets. Moving a little bit forward about different medications, I'm going to talk about Pluvicto, which is kind of the newer thing that we are doing for patients with advanced prostate cancer. This is indicated in patients with advanced prostate cancers that have already been treated with chemotherapy and with the secondary hormonal therapies like Xtandi and Zytiga. The patient has to have a positive PSMA PET scan in order to be able to receive this medication. It's a medication that's given by the nuclear medicine doctors, sometimes the radiation oncologists. The Pluvicto is a prostate-specific membrane antigen, or PSMA. The PSMA is expressed in the prostate cancer cells, and the Pluvicto binds to this PSMA. It delivers radiation to these PSMA expressing cells that results in DNA damage and cell death. We don't have it yet at Lynn, but hopefully we will have it soon. As I told you, it's for PSMA positive disease, and it's to be used in patients that have received chemotherapy and Zytiga or Xtandi before. The side effects that we see commonly are myelosuppression. We see a lot of that. That's low blood counts. So patients can have low white blood cell count, and that puts them at risk for infections. They can have anemia. We see dry mouth. We see gastrointestinal side effects, meaning nausea, vomiting, abdominal discomfort, indigestion. And we see a lot of renal dysfunction as well sometimes. Another thing that we use, we haven't been done it recently, but it's still FDA approved, and it's been replaced, I think, for Pluvicto mostly, is the Xofigo or radium-223. And then again, this is a medication where an isotope targets bone metastasis and increases cell death. Is for patients with bone metastatic disease, patients with prostate cancer, advanced prostate cancer that have only bone involvement and have symptoms from those bone metastases. This medication can cause peripheral edema, GI side effects like nausea, vomiting, indigestion, even diarrhea. and low blood counts as well. As I just told you, we don't use it very frequently, but it says it's still FDA approved for patients with advanced prostate cancer and bone metastasis. Now moving about a little bit forward, I'm going to talk about targeted therapy. So these are medications that we can only use in certain types of prostate cancers that have certain mutations. So I'm going to talk about these medications. They're PARP inhibitors. This is an enzyme, the PARP is an enzyme that is involved in the DNA transcription, and it regulates the DNA cycle. So these medications, Lynparza and Rubraca, they inhibit this enzyme, but they're only indicated in patients that have these mutations, BRCA1, BRCA2, ATM, MLH1, MSH2, MSH6, and PMS2. But we see the most benefit in patients with BRCA2 mutations. These medications are oral medications. They're taken by mouth, and they can be very effective in this kind of patients. The side effect that we see most commonly is hematological toxicity, meaning low blood counts, mostly anemia. That's what I have seen the most. They can cause some lung inflammation and gastrointestinal side effects. But then again, they're only indicated in certain patients that have these mutations. And lastly, I'm going to talk about immunotherapy, which is what we use in cancer mostly these days. There is this medication called pembrolizumab, commercial name is Keytruda. It's indicated for patients with advanced prostate cancer that have received chemotherapy or another hormonal therapy and have overexpression of the PD-L1 receptor or high microsatellite instability. So when we diagnose a patient with prostate cancer, we do this molecular testing to look for these mutations, to look for the PD-L1 expression. And if patients have an overexpression of the PD-L1, we know that they can be treated with pembrolizumab at some point. It's very well tolerated. It's an intravenous medication. It's used for a lot of cancers, so we have a lot of experience with it. Most people do fine. Most people don't have significant side effects, but the side effects that we can see are mostly side effects related to hyperimmunity. And that can be anything. The things that we see most commonly are thyroid disease. We can see skin rashes or dermatitis. We can see diarrhea or colitis. We can see respiratory side effects like difficulty breathing, cough, and that may be a result of lung inflammation called pneumonitis. So I think that's all for systemic therapy for prostate cancer. And I think we can move on to the questions.
Thank you so much. We've had some comments. Any questions from anyone? I don't see any questions. I think in my introduction, I mentioned the importance at LCI of treatment options, expertise of our staff, and latest technology. And I think each of you really covered that to showcase what we offer here, especially for our patients with prostate cancer. So thank you, doctors. I think you all covered the topics so well that I don't see any actual questions. Wait a minute, here comes one maybe. What is your SBRT machine?
That's probably directed at me. This is Dr. Casper in radiation oncology. So we have many machines that can deliver SBRT or stereotactic body radiotherapy. This is a very precise, effective way of delivering radiation, targeting the cancer and avoiding the surrounding structures. We have traditionally used the CyberKnife for SBRT. We do KV imaging, that's regular x-rays to try to isolate the tumor. Sometimes that's a problem. We can see it very effectively in the lung, and we can see tumors or we can localize tumors well in the brain, but frequently we have to place fiducial markers, which can present a challenge in the liver or in the lung or other areas where we can't quite see the tumor. If it's dense enough, we can see the tumor in the lung, and we do use the CyberKnife for SBRT. We also have a machine called the Radixact, and this is a tomotherapy machine, which has certain advantages as well. We now use the MR Linac for SBRT as well, with the imaging that I showed you, the direct full-time live MR guidance. And we can also use it on the Varian True. We can do SBRT on the Varian TrueBeam, which allows certain advantage. It has certain advantages as well. So the beauty is that we have a full gamut of equipment that allows us to assess the patient and assess the tumor, and then see which machine is best for you. So we're very fortunate to have very advanced, wonderful equipment to deliver the best treatment.
Thank you, Dr. Casper. And thank you, each of you. That was very comprehensive, very excellent education. Oh, there's one more question. Do you want me to read it? Do you get any efficacy switching between novel agents, i.e. abiraterone to, okay, I can't read it, the medications if there's a POD? I know by the book we're not supposed to, but in practice it's sometimes done.
What was the question again?
Can you see it on the Q&A? I don't know if you can see it.
No, I can see one about Gleason 6 and active surveillance, but I cannot see the one you just read.
Okay, this one said, I'll try to pronounce the medications. Do you get any efficacy switching between novel agents, i.e. the medication is
Abiraterone.
to ENZALUT enzalutamide?
Yeah, so I believe the question
If there is a POD.
Yeah, I believe the question is referring on whether we should change from abiraterone to enzalutamide or vice versa when there is disease progression in one of them. So sometimes we do it when we don't have other options, but usually a patient that becomes resistant to, let's say, abiraterone, it's unlikely to respond to enzalutamide in a meaningful way, and vice versa. So most times we try to avoid that.
Yeah, he goes on to say, I know by the book we're not supposed to, but in practice it is sometimes done. Okay, thank you for your response. I think that answered the question. I want everyone to know that these lectures are recorded. So if you'd like to go back to review the information, or if you have family, friends, coworkers that you think would benefit from this education, you'll be able to go on our website and share the link with them. Lee will be sending the link along with our evaluation. And we really do appreciate you filling out the evaluation forms and returning them to us. It helps us in what we do. And if you have any suggestions on topics you'd like to hear about, we appreciate that as well. We're going to round out our men's health presentations with September 26th will be our lecture from Marie Mirande, our oncology dietitian, and she'll speak on nutrition tips and men's health. So thank you, everyone.
Jan, excuse me 1 second. There's one additional question about active surveillance for low risk. I think select, depending on the tumor. Muted. I don't know. Can everyone hear me?
Yes.
Depending on the volume of the tumor and, different clinical risk is.
Oh, you're kind of cutting in and out. Now you're on mute.
Here we go. So, it is in certain specific cases of low volume minimal risk, 3+4, low PSA, low volume disease. Watching on active surveillance is a reasonable approach in some of those patients.
Okay, thank you. Yeah, I didn't see that question, so thank you. Thank you, doctors. This was very, very informative, and I know everyone on this presentation appreciates it. We appreciate your time and all the time and effort that you put into the research and putting your slides together. They were excellent. So thank you, everyone. Have a good afternoon and a great weekend.
You're welcome.
you.
Thank you.
Thank you.